Welcome to the Care Transfer module. This is the 8th of 10 presentations in the course. By the end of this module, you will be able to describe characteristics of adults' healthcare to students and families, identify care transfer activities for IHP 504 and IEPs, support students during the care transfer, and list strategies to coordinate services with medical providers during the transfer. Adjusting to the differences between children's and adults' medical care is a major challenge for students and parents. The term culture shock describes the discomfort experienced when moving to a very different environment, for example, a rural village to a large city, or to a new country. It is normal to feel uncomfortable in a new, strange environment where old ways of doing things may not work. The care transfer is akin to culture shock. Prepare the student for some confusion and discomfort while emphasizing their ability to learn new customs. Pediatrics uses a developmental orientation with a focus on assisting children to acquire new skills over time. Providers often use a supportive approach to families and patients, which is non-judgmental. Adult-oriented providers might describe this as a paternalistic approach. Office staff tends to be warm, optimistic, and interpersonally oriented. This approach accommodates the family's competing priorities, school obligations, parent work responsibilities, and so forth. Adult medicine focuses on the diagnosis or disease rather than on the whole person. Adult medicine uses a specialist consultation model to treat chronic conditions. Providers share findings and recommendations in a written format more frequently than by phone or in a face-to-face conversation. Adult medicine facilities are much more businesslike and formal. The approach is less accommodating to the preferences and priorities of the patient. As discussed in Module 2, pediatric care uses the shared management model. In this family-oriented model, parents are the experts in the child's chronic condition. Adult medicine regards the patient as autonomous. Providers do not view the patient or the family as an expert in their own health condition. They may take umbrage at being schooled on the patient's needs. During medical visits, patients are seen alone. Practice staff members expect them to make decisions and function independently. Pediatric providers rely on parents' observations about the child's development, changes in their health status, response to medications, and so forth. The provider is responsible for active advocacy and oversight. Children with complex medical needs often receive care through condition-specific clinics. Adult-oriented providers conduct tests or procedures to diagnose a new condition. They rely less on the observations of the patient or caregiver, especially with new patients. Patients, rather than providers, have primary responsibility for oversight and advocacy, such as requesting that a specialist forward test results to the primary care provider or getting prior approvals from insurance. Primary care providers typically refer patients with complex needs to multiple specialists. The patient sees these providers sequentially over time on different days and in different locations. Condition-specific clinics are less common. Pediatric clinics and practices have an established multidisciplinary model with easily accessible care coordination, services, and supports. Nurses and other staff provide medical care and psychosocial support. Staff roles and responsibilities are more differentiated in adult medicine. Nurses and other staff address only medical issues. They refer to social work for non-medical needs or for psychosocial support. It is also important to note that care coordination, supports, and services staff are less accessible in adult medicine. When pediatricians use the word transition, they usually mean transferring care from one place to another place. They also use it as shorthand for the transition to adult-oriented care. Adult-oriented providers use the phrase transition to refer to a transfer in the care location. They are generally unfamiliar with the use of the phrase in the context of transition to adulthood. Despite the barriers, the transfer remains crucial for continuous, accessible medical care. Many children's hospitals and facilities have policies regarding the maximum age of patients. For example, Nemours Children's Clinics cannot serve individuals over the age of 21. Insurance reimbursement, professional guidelines, and licensure laws may also require a care transfer between the ages of 18 and 22. Many students and parents see the transfer as a loss. This is especially true for students with complex conditions. Over the years, their pediatrician may have provided a life-altering diagnosis, emergency care, referral for an important surgery, or new treatment. Despite the challenges, there are many benefits to working with adult-oriented providers. From vital signs to prescription dosages, adult-oriented providers anticipate natural changes in health that come with aging. They frequently have difficult conversations with patients and caregiver family members, for example, about guardianship. The key is that they usually do this with their elderly patients and not with their youngest patients. Finally, adult-oriented providers are accustomed to learning about new conditions. They are fully capable of learning to treat your students. Some students learn about transition on what becomes their last visit. This type of abrupt discharge and transfer frequently leads to an interruption in care. Let the student know that it is okay to find a new provider if the first referral is not a good fit. Dropping out of care is not the next option. Educators may only find out about care transfers if they create a crisis for the family. Has this happened to your students? If so, how did you become aware of the issue? Take a moment to consider these questions. The presentation will automatically resume in 1 minute. Educators see students much more frequently than healthcare providers. If a patient drops out of medical care, school staff may find out before a new doctor does. Recall the 8 steps of the transition process. The final steps in this process focus on the successful movement to new adult providers, to adulthood, and to a new healthcare system.
Yeah, at the age of 18, Dr. Shapiro offered me, shall I say, another alternative. Instead of seeing him, I could see somebody that deals with older patients. I chose to stay with Dr. Shapiro because he has seen me basically since I was born. I mean, he knows me better than any other doctor. And I personally didn't and continue not to feel comfortable going to somebody who, in a sense, has to learn my case report all over again. I mean, I've always felt very comfortable with Dr. Shapiro. I know he makes very competent decisions regarding my care, and I will continue going to him for the foreseeable future.
Can you think of any reason why you might ultimately transition from Dr. Shapiro?
At this point, I really can't see any reason not to continue seeing Dr. Shapiro. Obviously, if something were to happen to him, then yes, I'd have to. But Boston is certainly a reasonable trip for me to make, and if it means that I'm getting the best quality care, which I believe I get at Children's, then I will continue going there.
What is it like as an adult going to Boston Children's? Do you have thoughts or feelings, or do you have a sense that you're an adult in a children's hospital?
To be honest, I never really thought about what it's like being an adult at Children's. I mean, I go there, I see Dr. Shapiro, I leave, whatever. Because I think a lot of that has to do with the fact that I had all of my surgeries there and I was always there. That it just always felt natural going there. So, in a sense, I think it would almost feel different going somewhere else and seeing somebody else, especially in regards directly to my disability.
Good transition planning is the best way to preempt or address barriers associated with a care transfer. Medical providers can have a huge impact on the overall transition to adulthood in ways both positive and negative. The National Center for Healthcare Transition Improvement provides 6 core elements of transition based on the practice setting. Encourage the family to find out what types of primary care providers they see. Pediatricians only treat children. Family physicians, or meds-peds, see all ages. Knowing their doctor's field will help plan for the timing of the transfer. Many pediatric practices write a practice transition policy that proactively outlines their process. Such policies support transition and avoid interruptions in care. Encourage students and parents to find out if their providers have such a policy in place. If the pediatrician does not have a transition policy, it will create barriers related to the care transfer. If they do have a policy in place, it will help your transition plan development and prepare the student for transfer. Opening communication between providers, educators, students, and families can avoid duplications in transition plans and help everyone work toward the same goals on the same timeline. This section provides strategies to prepare students for the transfer and tasks to include in their IHP, 504, or IEP. Families tend to forget how things went when they started with their current providers. Just as they learn to negotiate the pediatric healthcare system, they will also develop abilities for the adult healthcare system. Talking about these past experiences may help youth and families appreciate that building trust and respect takes time. During the transfer, the student is the decision maker with full responsibility for oversight and self-advocacy. Remind the parent of the shared management model and clarify their role during transfer. The path to independence, first discussed earlier in the course, remains a useful tool throughout this transition stage. Use the care transfer as a marker that the student is ready for independent completion of tasks. The transfer is an opportunity for the student to rise to the top of their abilities. The care transfer to a new doctor should not coincide with other important or difficult changes during late adolescence. Students who are starting college may not be thinking of finding a new doctor as part of their move. However, even simple chronic conditions like asthma or ADHD need advanced planning to manage. Engaging medical providers in the school-based plan is a natural time to enlist them in the care transfer process. Include specific items for youth with special healthcare needs based on the student's assessment results and the new provider's familiarity with the condition. Healthcare providers should discuss the fields of primary and specialty medicine with the student, help locate new providers, and clarify the new provider's field, especially when making multiple referrals. Prepare the student for making initial contact with the new provider's office and doing research before the first appointment. Students should make a list of questions for the initial visit. What is one task for the care transfer that would fit into an IHP, 504, or IEP? Take a moment to consider this question. The presentation will automatically resume in 1 minute. Before closing this module, let's look at resources for your school. The ultimate goal of transition preparation is a smooth transfer to adult medicine that provides continuous and accessible care for the student. Use the links from this course's toolkit to access the tools from this module. The next module reviews key points and resources from the entire course. You can pause here for a break or continue automatically into the next presentation.